Memory problems. Letter of referral. Dear Dr. Mr. Jack Shaw, aged 60 years. I'd be grateful if you could review this 60-year-old retired schoolteacher who has had episodes of forgetfulness for the past 2 months. His elderly mother, who he cared for, died 6 months ago from probable Alzheimer's disease. Please could you advise me as to whether you feel his memory problems are the early stages of dementia, as he is especially concerned about this. His past medical history is pretty unremarkable. He was diagnosed as having hypertension about 5 years ago and has been on amlodipine and bisoprolol since then, with BP 140/78 mmHg when last checked. Yours sincerely. Introduction. Dementia is the impairment of cognitive function affecting the content, but not the level, of consciousness. It is essential to obtain an independent description, e.g. from a relative, since a forgetful patient's history may be unreliable. This will not be possible in PACES, although details may be given in the letter of referral. There are many causes of dementia, but it is particularly important to rule out those that are potentially reversible. Differential diagnosis of dementia. Common: Alzheimer's disease, multi-infarct dementia/subcortical, ischemic leukoencephalopathy, dementia with Lewy bodies, DLB. Uncommon: alcohol-related, hydrocephalus, Parkinson's disease, Huntington's disease, Creutzfeldt-Jakob disease, CJD, frontotemporal dementia, tumors, drug toxicity, hypothyroidism, chronic subdural hematoma, vitamin B12 deficiency, neurosyphilis, AIDS dementia complex. NB. The commonest and most important condition to distinguish from dementia is depressive pseudodementia, which is eminently treatable. History of the presenting problem. What are the characteristics of the memory impairment? After a general inquiry along the lines, give me some examples of the problems you've been having with your memory. Ask the following questions if the relevant details do not emerge spontaneously. Was the onset of memory difficulties associated with a precipitating cause, e.g. a head injury causing a subdural hematoma? Was the onset of the dementia subacute, e.g. in normal pressure hydrocephalus or CJD, or chronic, e.g. in Alzheimer's disease or vascular dementia? Is the course of the dementia gradual or stepwise in progression? The latter is seen in multi-infarct vascular dementia. Is there fluctuating cognitive impairment affecting both memory and higher cortical functions, e.g. language and visuospatial ability, suggesting DLB? Does the patient seem slow, with disturbance of attention and motivation? This is more suggestive of so-called subcortical dementia. As the name implies, there is less cortical dysfunction and more disturbance of structures such as the basal ganglia and basal forebrain. Subcortical features are less likely to be seen in Alzheimer's disease but may be seen in a wide variety of pathological processes affecting these deeper subcortical structures, including vascular dementia due to small vessel disease or subcortical ischemic leukoencephalopathy. Is there prominent behavioral disinhibition, loss of social skills, emotional blunting and language dysfunction? These features, together with personality change, are seen in frontotemporal dementia. Associated features. Are there any neuropsychiatric symptoms, e.g. depression, apathy, or irritability, or motor abnormalities, e.g. extrapyramidal features? These are more common in subcortical than cortical dementias. Are there delusions, visual hallucinations, or the disturbances of sleep pattern associated with the motor features of Parkinsonism, suggesting DLB? Is there any gait disturbance or urinary incontinence, suggesting normal pressure hydrocephalus? Is there associated headache with features suggesting raised intracranial pressure, e.g. it is worse on awakening, stooping or coughing? Other relevant history. Are there atheromatous vascular risk factors, e.g. smoking, hypertension, as in this case, or diabetes, cerebrovascular events, e.g. strokes, or signs of heart disease, e.g. atrial fibrillation? Could there be hypothyroidism? There is a family history of dementia in this case, but always pursue this possibility in every patient, not only because there may be a genetic cause of the condition, e.g. familial Alzheimer's disease or Huntington's disease, but also because it is very likely to explain why a patient is so concerned about the possibility, even if there is very little evidence to support it. A detailed drug history is essential, but drugs tend to cause confusion rather than dementia. Take a detailed sexual history. Neurosyphilis is now extremely rare, and assess alcohol intake. As always, adopt a tactful approach, explaining why you need the information before embarking on direct questions that some might find intrusive and objectionable. Sometimes alcohol can cause problems like this. Are you a heavy drinker now? Have you ever been a heavy drinker in the past? Some infections of the brain can rarely cause this sort of problem, the sort of infections that can be spread by sexual contact. Who have you had sexual contact with in the past? Could this be depression, perhaps precipitated in this patient's case by the death of his mother? How is his mood? Does he enjoy anything? Has he lost interest in things he used to do? Is he tearful at times? What time does he wake in the mornings? Has he felt depressed or thought of his death/suicide since the death of his mother? Plan for investigation and management. Investigations. Any clinical clue to the conditions listed in Table 5 should be followed, but controversy surrounds what constitutes a cost-effective series of investigations because of different estimates of the incidence of reversible dementias. Many physicians would consider the following. Blood tests. Check FBC, electrolytes, renal, liver and thyroid function tests, inflammatory markers, erythrocyte sedimentation rate or C-reactive protein, serum vitamin B12 level, and syphilis serology. Genetic testing may be useful in familial Alzheimer's disease. NB. Genetic testing raises complex ethical issues. The consequences of genetic testing must be carefully considered, as significant harm can result from inadequate counseling. Neuroimaging. This is used to rule out structural and sometimes treatable causes of dementia such as tumors, normal pressure hydrocephalus, or chronic subdural hematoma. In cases of Alzheimer's disease, CT or MRI scans of the brain show cerebral atrophy, especially in the medial temporal lobes, whereas single photon emission CT, SPECT, shows temporoparietal hypoperfusion. MRI may play a role in the early diagnosis of Alzheimer's disease, which will be crucial if and when treatments that are effective in slowing progression of the disease become available. Cerebrospinal fluid. Testing of the cerebrospinal fluid, CSF, is rarely warranted unless there are atypical clinical features such as systemic symptoms, rapid progression, or unusual signs. The CSF cell count, protein, and glucose are normal in patients with Alzheimer's disease. S100 and 14-3-3 are two proteins that can be measured in the CSF, and may be raised in any condition where there is rapid neuronal loss and gliosis such as sporadic CJD. If neurosyphilis is suspected, then treponemal serology should be performed on the CSF, and empirical treatment commenced if there is doubt. Electroencephalography. This is not particularly useful because of the overlap in electroencephalogram patterns in different forms of dementia. In Alzheimer's disease there is a loss of alpha activity and an increase in diffuse slow waves. In sporadic CJD there may be periodic sharp waves. Management. Management will depend on the precise diagnosis. For Alzheimer's disease, patients should be reviewed after their investigations and trial of treatment where appropriate. NB. If a depressive element is suspected to be contributing to some or all of the clinical picture, then a trial of antidepressants is warranted. Further discussion. It is very common in patients with depressive pseudodementia to have a high degree of insight into their memory disturbance, whereas in cases of Alzheimer's disease, after the initial stages, patients often have very little awareness of their memory problems and are often not distressed by their difficulties. A close friend or relative is therefore essential for accurate history taking, and in PACES you would emphasize that you wish to talk to a relative/close friend to supplement your history from the patient.